So next, I would like to introduce Dr. Saptarshi Bhattacharya to present on this very important aspect of inpatient management, that is metabolic and encephalopathy endocrine perspectives.
Very good morning to all of you. So this is something I think metabolic encephalopathy. So when we go for seeing some taking a rounds in ICU, so maybe if there are 15 patients admitted, so out of that, in 3, 4, 5 will be it will be written metabolic encephalopathy, and and there is some amount of lack of clarity about what is it. So what in the next 15 minutes I will try to do is give clarity about what is metabolic encephalopathy, what are the endocrine connections to it, and some common endocrine connections which can actually cause metabolic encephalopathy, and finally to summarize. So to start with, what is confusion? The inability to maintain a coherent stream of thought or action. And what is delirium? So if there is a confusional state, and on top of that, if you have superimposed hyperactivity of the sympathetic limb of the autonomic nervous system, so that is delirium. And metabolic encephalopathy can encompass both the delirium state and confusional state, and it's a global cerebral dysfunction, and it should be reversible on removal of the cause. And the most important thing, it should not be due to a primary structural brain disease. So if you are having, if somebody is having a CVA or stroke, so then you can't label it as metabolic encephalopathy. The definition by Wilson around 15-20 years back, it's a clinical state of global cerebral dysfunction induced by systemic stress that can vary in clinical presentation from mild executive dysfunction to deep coma with decerebrate posturing. So the key features I already told: global cerebral dysfunction, absence of structural brain injury, it should be reversible, there should be lack of consistent focal features, and should be acute or subacute in onset. So what are the clinical clues? So it is usually associated with concordant organ system dysfunction. It usually can have a fluctuating course. If there are bilateral tremors or asterixis or multifocal myoclonus, those can indicate the possibility of metabolic encephalopathy. So if the pupillary function is absent, if so, that practically rules out metabolic encephalopathy. So the hallmark is the pupillary function should be preserved, and cranial nerve involvement is again rare. So these are the gross causes. So one is organ failure, hepatic failure or renal failure. So if there is lack of glucose or oxygen, hypoxia or hypoglycemia, and metabolic derangements like vitamin deficiency, electrolyte alteration, and other toxicities. Just to summarize, so it's a long list: hypoxia, ischemia, systemic disease, toxic agents. Just to summarize, and the basic investigations, if you are suspecting that somebody has metabolic encephalopathy, are CBC, KFT, including calcium, magnesium, and phosphate, coagulation studies, plasma glucose, very important, ammonia levels, liver function test, serum osmolality, arterial blood gases. So if you are suspecting some toxic etiology, toxicological screening. To rule out infection, you need to do blood and CSF cultures, thyroid function test, and vitamin B12 in suspected cases. We have sessions on hypercalcemia and vitamin B12 deficiency during plenary. I think I'm sure we'll have more discussion on those two aspects. And these are grossly the endocrine causes. So if you are looking at dysglycemia, the number one most common cause is hypoglycemia. Then we have diabetic ketoacidosis, it can also cause metabolic encephalopathy, and HHS, which is hyperglycemic hyperosmotic state, that also can cause metabolic encephalopathy. All electrolyte derangements, thyroid dysfunction, and adrenal dysfunction can cause. So these are usually the symptoms of hypoglycemia, where you start having neuroglycopenic features are between 50 to 55, if less than 50 milligram per deciliter, around 55 or so, you start having the autonomic symptoms, and there is a huge variation. So if somebody is having persistent hypoglycemia, recurrent hypoglycemic episode, so even the threshold can go down and the patient can go into coma straight away, and this is the mechanism. I am not going to go into the details of it. So this is how this is anybody, what is the diagnosis? Okay, so this was an 18-year-old boy having recurrent episodes of hypoglycemia, having an insulinoma, and there are hyperintensities in the area of the caudate nucleus in the basal ganglia, and there is, so this is something which we need to be careful. Obviously, we are all very careful about hypoglycemia in a diabetic individual, but there are hypoglycemia occurring in non-diabetic individual as well. So it's usually, you will need to look into the clinical status. So if somebody is critically ill, having CKD, sepsis or CLD, admitted in the ICU, so maybe you need not go into a very detailed workup for that. But if you are looking into hypoglycemia in a apparently well person, so if somebody is non-diabetic and having hypoglycemia, then you need more detailed workup. So actually you need to document it, low blood glucose and simultaneous corresponding insulin values, C-peptide values, beta hydroxybutyrate values, pro-insulin values. So these two are not very easily available, but if you have the facilities, you should get that. And if sometimes you are not able to get a spontaneous hypoglycemia documented and having these corresponding values, then we might have to subject somebody to a 72-hour fast. So I'm not going to go into the details of all this, but hypoglycemia might require, especially in a non-diabetic individual. So there is one entity which is called reactive hypoglycemia, which will cause more of adrenergic symptoms, sympathetic symptoms, less of neuroglycopenic symptoms, but then they usually have a pre-diabetic tendency. But for in all other cases, you really need to be careful. So again, anybody, what is the diagnosis? So this was the opposite. This was very high blood sugars. So this person was having hemichoria and hemibalismus of the right side. So the left side shows asymmetric hyperattenuation involving the lentiform and caudate nuclei bilaterally, and it's more pronounced on the left side. So this patient, sometimes we see they are coming with hemichoria, hemibalismus, flinging their arms, and once the blood sugar is 500, 600, so gets a detailed neurological workup. And actually, if the sugars come down, the movement over the next 1 to 2 weeks, it settles, even it settles sometimes in 1 to 2 days. So this is another important etiology of endocrine metabolic encephalopathy. So this is another situation where we can actually get neurological involvement or metabolic encephalopathy is diabetic ketoacidosis. Again, the mechanism can be vasogenic, osmotic or cytotoxic, and you actually need to be careful about cerebral edema in the setting of diabetic ketoacidosis. So it's more common in pediatrics. So if a child comes with diabetic ketoacidosis and is seriously ill, so you need to be very, very careful about cerebral edema and give a slower correction. In adults, the chances of cerebral edema is less in the setting of diabetic ketoacidosis, and so younger age, newer onset diabetes, longer duration of symptoms, they all predispose to a higher risk of cerebral edema. There are some other risk factors as well, but again, if you are for a child, you really need to be careful. So this is how a cerebral edema CT scan will look. So you can't see the ventricles practically here, just very small. So this is after correction. So the sulci and all those, those are now visible. The ventricles are becoming more apparent. So this is again a reversible cause of endocrine metabolic encephalopathy. So again, there is a long list of electrolyte abnormalities. We all know that hyponatremia, hypernatremia, hypocalcemia, hypercalcemia, hypophosphatemia, hypomagnesemia and hypermagnesemia. So they can all cause metabolic encephalopathy. So there are some key features. So usually acute symptomatic hyponatremia, it can cause drowsiness, other symptoms, headache, and nausea is usually key feature. If it's chronic, it will be asymptomatic. If in case of hypocalcemia, so there will be associated tetany, carpopedal spasm, cramps. In case of hypophosphatemia, there can be GBS-like presentation, myopathy. So this is another clue which can, extra clue which can guide us to the diagnosis. Again, in case of hypomagnesemia, cramps and hyperreflexia can occur. In case of hypermagnesemia, sometimes usually used to occur earlier in the setting of PIH, severe preeclampsia, when were given excess of magnesium sulfate. So severe limb weakness or diaphragmatic weakness, you again need to be careful. So now we move on to thyroid, which is also, which can affect the neurological function in two forms, two well recognized forms. One is myxedema coma and the other is Hashimoto's encephalopathy. So these are two different entities. Myxedema coma is very severe hypothyroidism having cerebral involvement. On the other hand, Hashimoto's encephalopathy is more of a diagnosis of exclusion. So if you are not getting anything, if the person is having a thyroid disorder, if you document a TPO antibody or a anti-thyroglobulin antibody to be positive, and you have associated features of encephalopathy with seizures, myoclonus, hallucination or stroke-like episode, symptoms are usually subacute or acute. Brain MRI is usually normal. So if you are having a finding, then you need to actually look at that cause. So the thyroid antibodies should be present. CSF examination should be done, and there should be absence of neuronal antibodies, and there are some studies which have actually suggested that you can do a thyroid antibody, thyroid peroxidase antibody in the CSF as well. And it's a, you first of all need to exclude other cause. So this is a entity which management is totally different. So you need to give steroids and then and it's very responsive to steroids. So but again, we in our ICUs, in our hospital, we keep on discussing whether this is possible or not. So if somebody is having altered sensorium state and only the known case of thyroid disorder which is apparently well controlled, maybe the TSH and T4 will be normal, but the TPO antibodies are very high. So whether you are going to suspect Hashimoto's encephalopathy, so this is a gray area where some people will tell we don't believe that it even exists, but this is something which still we need to understand. So Cushing syndrome itself can also cause multiple changes, and the EEG findings are usually helpful in most of these cases. So they all have hyperthyroidism, there will be more chance of epileptiform activity. Hypothyroidism, there will be slowing down. So most of these electrolyte abnormalities and endocrine abnormalities, they will have some EEG abnormalities. But a very important additional point you need to know into, so that it's a very important differential of metabolic encephalopathy is non-convulsive status epilepticus. So if somebody, so the symptoms might be very similar, the manifestation might be very similar. So if you are seeing NCAC in an EEG, and if you are not having any other cause, so most probably the person will require anti-epileptics rather than anything else. There is an entity called posterior reversible encephalopathy syndrome. It's acute or subacute neurological symptoms with headache, impaired visual acuity or visual field defects, disorders of consciousness, confusion, seizures and focal neurological deficit. Usually occurs with very high BP, hypertensive urgencies and emergencies. MRI will show a distinctive parieto-occipital pattern with a symmetric distribution, and there are some endocrine causes to it. So if somebody is having pheochromocytoma, primary hyperaldosteronism, hypercalcemia, hypermagnesemia, so mostly the causes are renal diseases or immunosuppressive drugs or autoimmune disorders, but there are some endocrine causes as well about which you need to be careful in this state. So the discussion wouldn't have been complete if because the first thing which is done in clinical practice, okay, metabolic encephalopathy, get an serum ammonia level. So where do we actually need to get it? So if the person is having liver function disease abnormality, having chronic liver disease, cirrhosis, so obviously that is the most common cause of elevated ammonia and metabolic encephalopathy. But if there is no evidence of any liver disease, so there are 4 to 5 situations where the ammonia levels can be elevated. One is medications like valproic acid or chemotherapy. Number 2, infection with urease producing bacteria. recent surgery like lung transplant, bariatric surgery, ureterosigmoidoscopy, errors of metabolism altogether a detailed worthy of a detailed discussion by itself. So then so usually occurring in children, even there are adult errors of inborn error of metabolism, so again it's a detailed discussion. And hyperalimentation, so if in more of protein, maybe in the form of TPN or excess protein, so that time can also cause it. And treatment we need to, even though, so if the ammonia levels are elevated, we really need to look into the cause rather than just giving rifaximin or lactulose. So another very important concept is that what is the difference between dementia and delirium. So dementia, so it's considered to be irreversible. So there will be so if somebody is coming with a delirium state or an encephalopathy state, so if there are people who have underlying dementia and they are also more predisposed to delirium. So it's important to identify the reversible component. So there might be an infection or a uncontrolled hypothyroidism or a elevated blood sugar or maybe a CO2 retention which might have worsened it. So all those patients who are having underlying dementia, don't think that any worsening is just a part of the dementia. You always need to rule out whether there is some underlying metabolic component to it or not. So finally, to summarize, normal neuronal activity requires a balanced environment of electrolyte, water, amino acids, excitatory and inhibitory neurotransmitters and metabolic substrates. Delirium with either an agitated confusion or somnolence or impaired attention, tremor, myoclonus and asterixis and coma. These are the features of metabolic encephalopathy. It should be reversible. There should be no structural lesions underlying, and usually whenever the reversible component gets corrected, the symptoms usually resolve. Identification and treatment of the cause are the most important part of this disease. Thank you. I think if you we'll have the questions during tea, I guess.
Thank you, Dr. Saptarshi Bhattacharya, for such a wonderful deliberations on an important topic of metabolic encephalopathy, and it's a challenging diagnosis for neurologist and the endocrinologist. Now I invite Dr. Rajiv Singla to come on the stage so that we can have some question answers from the audience. House is open for the questions. Any questions on diabetes reversal or metabolic encephalopathy or any other question related to any endocrine disorder?
This question is for Dr. Rajiv. You elegantly demonstrated the reversibility with lifestyle modification. Now, my question is, before the direct study, bariatric surgery was proposed as the method of reversal of diabetes. And they adopted a ABCD rule: A1C, BMI, C-peptide, fasting and duration. So how important is the estimation of C-peptide fasting, considering that we have a large variety of diabetes? So a person with a robust C-peptide and dominant insulin resistance would be a better candidate?
Yeah, so I think that's a very, very valid point. So C-peptide is a good surrogate marker of what your residual beta cell function looks like. Of course, when we look at clinical practice, what we try to see is that if we can use some clinical markers as a surrogate for not doing all those investigations. There are certain issues with C-peptide while you measure them in practices. Somebody is already on insulin, somebody is already on sulfonylurea, so you really might not have a clear idea what your baseline C-peptide looks like. But yeah, C-peptide is a very, very good marker and can tell us as to who is more likely to get reversed. Bariatric surgery, of course, again makes you lose that weight. So if you look at very low calorie diet studies, over 6 to 8 weeks, their benefit has been as much as bariatric surgeries. And now with people getting all these problems much earlier in their life, what they have also realized is now in all bariatric surgery conferences, you would be hearing their main focus is on weight regain. Right? So what we eventually realized was that patient selection for bariatric surgery also is very, very important. And these lifestyle changes that we ask them to do even after bariatric surgery, has to be continuously reinforced?
You laid mostly emphasis on the diet. What about exercise? I feel most important is exercise if one does it regularly, whether aerobic and with isometric, can remain and eat everything. I am 80 years young in front of you.
Yeah, so
My HbA1c is 5.4. I do exercise every day, 40 minutes in the morning and 30 minutes brisk walk in the evening, and I eat everything. You just walk and you walk with me, you will know how old or how young I am.
yeah, so congratulations to you, sir. No doubt about it. So, of course, it is all about a combination of diet and exercise. What we believe is that to start with, when somebody starts on this journey of lifestyle change, initially diet plays a larger portion as compared to exercise. Not to underestimate exercise at any point of time. And in fact, once somebody's lost their weight or reached where they want to reach, then exercise plays much larger role in maintaining that. What we have also seen in our practice is that they both go hand in hand. People who are more compliant to diet, to exercise, are more likely to comply with diet also. When people leave both these things in conjunction. So either they are doing both diet and exercise, or they are not doing diet and exercise, either of them. So your point very, very well taken here. So,
Sir,
as
role of Dr. Rajiv, thank you very much for a very good, nice lecture. That in treatment of diabetes, as the first thing is to modify the lifestyle. Say take good exercise. Many patients whose blood sugar comes to be 200 or 250 in the beginning and having यूरिन शुगर ऑफ +2, वो ये कहते हैं कि डॉक्टर साहब आप दवाई ना लिखो, हम एक्सरसाइज करके आपको दिखा देंगे. एंड आई हैव सीन मैनी पेशेंट्स, their blood sugar level is very good control on taking good exercise. Second point, that is there any difference between the intake of carbohydrate diet? Say if a patient is taking lot of rice and other person is taking lot of wheat rotis, is there any difference? Because 2 years back I listened a lecture from USA. Say you were saying Roy Taylor's, that he has given this twin hypothesis for reversal of diabetes. He was from USA. His friend in England, he became very obese, 120 kg. He had MI, he had developed diabetes. Then he said that you should switch on to the only boiled rice. And that person in England, he took boiled rice only, no wheat, no other things. And he reduced weight about 20 to 25 in a period of 6 months. Diabetes disappeared, he became all right. Second question, there is a book that is Wheat Belly, because wheat has been blamed for creating this obesity and hyperglycemia. Thank you.
I will take half minute, sir.
Yeah,
I just want to not congratulate by comment the work of Dr. Singla. I know I have listened to him, and this is not as useful deliberation, because if we can reverse the diabetes, and as I have seen the slide, I think the most of the work is done by Dr. Singla, and we pray that he should be successful. Because if we can reverse to any extent the diabetes, then we can reverse the morbidity of the humanity. And I think you should continue this. And if we achieve this, then you will make the world happy and disease-free. Thank you, sir.
Role of ketogenic diet in diabetic reversal.
okay. So, so we've got 2 questions here. So, of course, ketogenic diets are we talked about, that if you bypass carbohydrate metabolism, then you're not utilizing all those, you don't really need insulin, you're switching your fuel source from carbohydrate to your fats. Only thing, it becomes little challenging to sustain that. You can reverse, but the remission that you're going to achieve, for how long it is going to last, that becomes a little question. So there are papers, there are people have been able to maintain remission a year on ketogenic diet. It's a good diet. We've used extensively in our practice also, but with vegetarians it becomes little challenge in long run.
Sir, it is healthy. Is ketogenic diet healthy in the long run? Not just for diabetic reversal or weight loss.
See, that's okay.
But
So
about the effect of on endothelium, effect of ketogenic diet on endothelium and all other effects.
Due to the paucity of time, can we take the questions and answers in the tea break, please? Discuss.
yeah. So ketogenic diet. See, everything in medical field is gray area, right? So you really can't have blacks and whites. So its ketogenic diet is like any other medicine that we use. So you have to select people, and then people who are appropriate for ketogenic diet, nothing else would work for them. It does wonders for them. As far as cardiovascular safety and everything is concerned, in fact, there are one that the data is not conclusive as yet, but whatever data is there is no conclusive data on harm. In fact, there are few papers who would try to tell us that the cardiovascular mortality does come down. And also we largely believe now what we eat is not reflected in your lipid profile. Right? What is reflected in your lipid profile is linked to your cardiovascular risk, but what you eat is not reflected in your lipid profile. So that's the
Thank you, Dr. Rajiv Singla.
Oh, for whatever you want, whatever anybody can continue it for.
Just a concluding remark, as you told, if the people is having a very long history of diabetes, say for 20 years or 30 years, then reversal is difficult. But I have come across with some old patients who had been taking oral hypoglycemic agents, but at the age of 80 they did not require any medicine. What is the reason for that?
Yeah, so see, if you look at your insulin sensitivity, so with age, beyond a certain age, your insulin sensitivity actually becomes better. So you would realize if you look in your practice, beyond 60-65 years of age, you generally don't require to escalate your anti-diabetes drug. So people who are on a very low dose of oral hypoglycemic drugs, say just on metformin, perhaps maybe plus gliptin, so few of them may actually come off medicines as they age.
Thank you so much. And so we conclude this session. Over to the moderator for the next session. Thank you so much.